So first we will discuss, this is just no topic, just for knowledge. This is oogenesis. So in a newborn child, in a fetal period, the female fetus has oogonia, which in fetal life they are connected to primary oocyte. Okay. Now meiosis once starts in the primary oocyte, but it gets arrested in the diploprotein stage of prophase till puberty age. Then at puberty, it resumes, and this primary oocyte converts into secondary oocyte and first fuller body. Okay, this is just oogenesis, normal information that you should know. Then ovary histology. What is present inside ovary? So ovary has cortex and medulla. Cortex is the outer part, medulla is the inner part. Okay, so these primary oocytes in a female child, that is, this is ovary of female child that has not yet attained puberty. So these are in red color, they are primary oocytes. In red, they are primary oocytes. Then these blue cells, the cortex has some cells that are called granulosa cells, and they surround this primary oocyte. Then and when granulosa cells surround the primary oocyte, they are called follicular cells. Okay, so these blue ones are follicular cells, and medulla has different types of cells, and one of them they are called stromal cells. Okay, because they form the stroma, that is a supporting tissue, and one of them is called theca cells, and they surround this primary oocyte again outside the follicular cells, then they are called theca cells. Okay, so medulla has blood vessels, stromal cells, and one of the stromal cells is called theca cells, and they surround the primary oocyte over the follicular cells. Okay, so primary oocyte, and this is termed as primordial follicle, that is, in a follicle surrounded by two layers, first by granular cells, then by theca cells, and has primary oocyte, and this is present in a prepubertal female child. Okay, so primary follicles number at birth is 1 to 2 million. Puberty, it is 500,000. That is, there is atresia or apoptosis going on in the follicles before the attainment of puberty. Okay, so when the menstruation cycle starts, that is, the female child attains puberty. Okay, then the hypothalamus secretes. So at the puberty age, the hypothalamus pituitary ovarian axis becomes functional. That is, these three correlate and govern the menstrual cycle. So hypothalamus pulsatilely secretes GnRH, which releases FSH and LH in the same manner. Okay, so what does FSH? FSH acts on granulosa cells, that is, follicular stimulating hormones. So it will act on two things, on the follicle and the follicular cells. So what are the follicular cells? Granulosa cells. Okay, so granulosa cells, it acts on granular cell. So first of all, follicular stimulating hormone acts on follicle. Okay, so what will these two follicles is that it stops the apoptosis, that these follicles are going under atresia. After FSH stimulation, their apoptosis stops and their proliferation starts. Okay, so the primordial follicles start growing. Then second action is on granulosa cells. So by action of granulosa cells secrete estrogen and inhibin B. Inhibin B feedback FSH inhibition and this estrogen. Okay, so what's the function of estrogen? So now this is ovarian hormone, that is, FSH from pituitary stimulate ovary and particularly granulosa cells, which secrete estrogen. So estrogen is ovarian hormone. Now estrogen has three functions. It inhibits feedback FSH, same as this. Okay, no problem. Then what is this feedback does is that we don't want more primordial follicles to get activated. So the FSH inhibited, and out of all the stimulated by this pulsatile FSH secretion, all the follicles that were stimulated, only one will remain, that will be called as dominant follicles, which had most FSH receptors, and all other will undergo apoptosis. Okay, so all the follicles that were stimulated by FSH, out of them only one will remain that has maximum follicle FSH receptors, and it will be called as dominant follicle. And this estrogen will also cause endometrial proliferation, and it will have a positive feedback on LH. Then pituitary also release LH. So this LH from pituitary and positive feedback by estrogen will cause a LH surge. Okay, what this LH does is it starts meiosis 1 in the primary oocyte. So primary oocyte was arrested in the diplotin phase. Then this LH surge resumes the meiosis 1, primary oocyte converts into secondary oocyte. This is termed as ovulation. Okay, so primary oocytes interaction of LH surge becomes secondary oocyte. And what LH surge do the dominant follicle, that the follicle that was grown by FSH and become the dominant follicle, the only one surviving, LH converts this follicle into corpus luteum. Okay, second action, then it acts on theca cells. Okay, so follicular FSH act on granulosa cell, this acts on theca cell, forms androgens. Okay, now these androgens that are type of male hormones that are present in a low levels in female, they enter into granulosa cell and adipose cells, that is in the peripheral tissue, and converted to estrogen by aromatase enzyme, and this is called peripheral conversion of estrogen. Peripheral conversion is only in the adipose cells. Okay, now LH also acts on granulosa cell, but this is not that much important. It causes luteinization and which releases small amounts of progesterone. Okay, this is not much important. Just remember that FSH acts on first follicle. What it does then, it acts on follicle, stop their apoptosis, convert the primordial follicles into and stimulates them. Out of all the stimulated, only one will remain, that will be called as dominant follicle. Then FSH acts on granulosa cell and secrete estrogen. What estrogen does, inhibit FSH and endometrial proliferation and positive feedback on LH. Okay, now what LH does, LH from pituitary and positive feedback from estrogen, this will cause LH surge. So what will the functions of LH surge? First, ovulation, that is primary oocyte of the dominant follicle will be converted to secondary oocyte and the dominant follicle will be converted into corpus luteum. Okay, so this is roles of FSH and LH. Now come to the phases of menstrual cycle. So menstrual cycle have two phases, follicular phase and follicular or proliferative phase. Second is secretory phase. So what is follicular phase? Follicular phase is first half of the menstrual cycle, that is day 1 to 14, and in this all changes occur in follicle, so it is named follicular phase. And there is endometrial proliferation also, that is why it's also termed as proliferative phase. Okay, so what happens in this, that is on day 1 FSH was released, granulosa cell stimulated, estrogen released, inhibition on FSH, only one follicle remain, dominant follicle. Then second effect of estrogen, endometrial proliferation. Then positive feedback on LH, which end into LH surge. So LH surge occurs just before day 14, and at day 14 ovulation occurs. So this in day 1 to 14, the FSH stimulation caused primordial follicle growth, that is first into preantral, then as size increase antral follicle, then as size increase graphene follicle. So the only one remaining primordial follicle that was stimulated, that is dominant follicle, grows into size and form preantral follicle, antral follicle, and graphene follicle just before the day of ovulation. When the ovulation occurs due to LH surge into the graphene follicle, the primary oocyte will convert to secondary oocyte and follicle itself will convert to corpus luteum. Okay, now comes the secretory phase. This is the second half of menstrual cycle, day 15 to 28. In its start, this occurs primary oocyte to secondary oocyte, follicle to corpus luteum. Now this corpus luteum, remember corpus luteum was formed due to LH surge, so it was formed, maintained and growth by LH. Okay, so under the effect of LH, this corpus luteum grows and attains maximum size and activity in 8 days, that is till the day 22 cycle. So now corpus luteum secretes progesterone mainly, some amount of estrogen and inhibin. Okay, and these two decrease FSH, so that because we got our ovulation, so we don't want any more follicles to be stimulated, so they decrease FSH as the normal estrogen does, and inhibin also have feedback inhibition of FSH, so also inhibin A. Now progesterone is mainly released by corpus luteum. What it does, that it has inhibition feedback on LH. Okay, so that we don't want any more corpus luteum. Okay, so all hormones that are, they have their own feedback inhibition loop. Like estrogen was caused by FSH, so it inhibits FSH. Progesterone was caused by LH, so it inhibits feedback on LH. Okay, so progesterone has secretory action, that is it supports the newly grown endometrium, that the endometrium that was grown in the proliferative phase by the estrogen, it supports this endometrium and stabilizes it. Okay, so when the LH is decreased by negative feedback by progesterone from corpus luteum, like this, progesterone has negative feedback on LH, so when this feedback acts, the LH decreases, corpus luteum start degenerating. So When corpuscles start decreasing, progesterone decrease. Progesterone decrease, support to newly grown endometrium lost. So newly grown support, that is superficial endometrium. Not whole of the endometrium is lost. Only the superficial grown endometrium sheds, termed as menses. Then, as progesterone decrease, vasoconstriction occur. PGF12 decrease, which causes pain during menstruation. That is known as dysmenorrhea. So dysmenorrhea is not some unknown condition. It's just as pain during menstruation, termed as dysmenorrhea. Okay, and it is a normal thing to occur. Then it may or may not occur, but it is a normal thing. Okay. Then corpus luteum start degenerating, decrease estrogen and decrease inhibin A, that is estrogen and inhibin A. So as they decrease, the FSH increase, next cycle starts. Okay. So for exams, you will know, you have to remember just this chart for menstrual cycle. Okay. So just remember this. Just RMY this, that all hormones peak at ovulation except progesterone, which is max at day 22, because at day 22 corpus luteum is maximum active. Okay. So all hormones, so this was our black is our FSH. So FSH rise, okay, before the LH. Okay. So if in the day about 10, FSH increase, but it peaks at day 14. Just remember, all hormones peak at ovulation. Okay, there is LH surge on the day 14. Okay, these are our pituitary hormones done. Then ovarian hormones. Okay, so estrogen was released by FSH. So here is the FSH. It will cause estrogen rise. Okay, this will also peak at day 14. Then it decreases. Okay, then here is a progesterone. So progesterone peak is at day 22. Okay, and it has no effect from LH FSH. It is released by corpus luteum. So it increases after ovulation. That is when the corpus luteum was formed. Okay, and this estrogen is increased here because of the corpus luteum. That is, corpus luteum also secretes estrogen. Okay, to keep FSH low. Okay, that's why this estrogen increased here. Now comes to the endometrium. Okay, so in endometrium, what happens is in day 0 to 5 there is menses going on. Then as the FSH released and the estrogen secrete, estrogen causes endometrial proliferation. Okay, then after the ovulation, the further endometrial proliferation and supporting of by progesterone occurs. So at day 22, maximum progesterone activity, so maximum stable endometrium. Then after that, as progesterone decrease, the menses start again. Okay, so now this is just for knowledge. That is, in non-pregnant female, source of progesterone is corpus luteum. In pregnant female, in first few weeks, it is corpus luteum of the corpus luteum from the fertilized ovum. Then this function is taken over by placenta. Endometrium in non-pregnant female is superficial endometrial proliferation. In this, whole endometrium proliferates, and there are different secondary changes in endometrium. And then this endometrium of pregnant female is called decidua. Then endometrium shedding in non-pregnant female is called menses, and in pregnant female, after delivery is done, when the placenta is removed and the progesterone source is gone, then this decidua is shed, and this will be termed as lochia. Okay, so this is just for OPD case. So if some female comes to OPD and that she says that she has expected periods from 15 Jan and she want to delay them by few days, 4 or 5 days, because she has some function or work at home. So we know that progesterone stabilizes the endometrium, which stops the shedding, that is the menses. So we will give progesterone pills 2 to 3 days prior. Okay, so that the shedding doesn't start before the expected date. So we will give tab Primolute 5 mg TDS. Okay, this contains progesterone. Okay, and when she stops taking pill after 2 to 3 days, her progesterone will start falling and the menstruation will start. Okay, so now if the patient complains of delayed menstruation, that her expected date was 15 date, but the period did not come, okay, even till the 25 Jan, because 4 to 5, about 1 week delay is not a major thing, because it can be due to some stress kind of things and behavior things, etc. So if the female was sexually active, that is in reproductive age group, during urine pregnancy test, if urine pregnancy test is positive, that is due to pregnancy. So in pregnancy, we know amenorrhea, that is irregular menstruation, because of the progesterone by corpus luteum and then by placenta. Then if the pregnancy test is negative, then conceptually what we should do is that we should decrease progesterone so that shedding will start. But the anti-progesterone like mifepristone, they longer to take, they have longer duration of action, that is the effect will appear in few weeks. So instead what we do is, we from our side we give progesterone lows like Meprate, that is medroxyprogesterone acetate 10 mg/d for 5 to 7 days. What it does is it keeps a high level of progesterone for few days, okay, more than the normal that the patient had. So now when we spontaneously stop the tab, the progesterone will fall suddenly and this will start menses. So now comes to bleeding. So normally bleeding is due to progesterone loss, and as the progesterone decreases, dysmenorrhea, that is pain also occur. So but if patient complains of painless and heavy bleeding, what does that signifies? This signifies that this bleeding is anovulatory. Okay, this is seen in early pubertal female, that when the puberty starts, in menopausal females, and in the PCOS patients. Okay, what is anovulating? That is, there is no ovulation. Okay, so no ovulation, no corpus luteum, because in ovulation caused by LH surge, and LH surge used to transform follicle into corpus luteum. So no ovulation, no corpus luteum, no progesterone, there is amenorrhea. Okay, but there is estrogen present, because estrogen is released by due to FSH stimulation from pituitary. So FSH from pituitary stimulates the granular cell which release estrogen. So estrogen causes proliferated endometrium. Okay, so there is no ovulation, so the estrogen keep on proliferating the endometrium, okay, beyond the expected date. Okay, because estrogen doesn't know when to stop. Okay, so estrogen keep on proliferating the endometrium, but progesterone is responsible for stabilizing this endometrium, but progesterone doesn't come. So this proliferative endometrium by estrogen, this is kind of unstable. So after few days, like 10 days, 20 days, 30 days, when there's this overgrown unsupported endometrium sheds, there will be massive bleed, one thing. Then it will be painless, because the dysmenorrhea, that is the pain during the menses, is caused by vasoconstriction by progesterone decrease, which led to PGF12 release, which causes pain. And here as progesterone is not absent, so all this is absent, that is painless bleed. Okay, so now come to AUB. AUB is any uterine bleeding outside normal volume, normal duration, or normal frequency. Okay, that is abnormal uterine bleeding. So what it can be? So it can be normal volume is approx 35 ml, range is 5 to 80 ml. So less than 5 ml is called hypomenorrhea. Okay, more than 80 ml will be called as menorrhagia, not polymenorrhea. It will become menorrhagia. Polymenorrhea is different condition. So less volume than normal is hypomenorrhea, more volume is menorrhagia. Same for duration of menses. Normal duration is 2 to 7 days. So less than 2 days is hypomenorrhea, more than 7 days is menorrhagia. Okay, so less volume, hypomenorrhea, less duration of menses, that is also hypomenorrhea. More volume and more duration of menses, that is menorrhagia, not polymenorrhea. This is the thing that you have to remember. So what is then polymenorrhea? So cycle length normally is 28 days and range is 21 to 35. So less than 21 days, that in 1 year the female will have to expect, or the female will have more frequent menses. That will be termed as polymenorrhea. Okay, not here. This is the polymenorrhea. Okay, so hypomenorrhea, not hypermenorrhea, that is menorrhagia. And for less than 21 days, polymenorrhea. And when the cycle length is 35 days, so throughout the year the female will have less menstrual cycle, that will be termed as oligomenorrhea. Okay, so now all these conditions, all these 4 conditions, hypomenorrhea, menorrhagia, polymenorrhea, these were in the regular cycles. So if the cycles become irregular, okay, or the bleeding is intermenstrual bleeding, that is in between the cycle, this will be termed as metrorrhagia. Okay, so AUB can be, if the patient AUB can be in 2 types of condition. Patient with irregular cycles, when the volume is less than normal, duration less than normal, hypomenorrhea. Volume duration both greater than normal, menorrhagia. Okay, then duration of cycle less than 21, polymenorrhea, greater than 35, oligo. But if patient has irregular cycles or the bleeding is intermenstrual bleeding, then it will become as metrorrhagia. And what if patient have both, that is heavy bleeding plus irregular bleeding? So for heavy we will have menorrhagia, and for irregular we have metrorrhagia. So menometrorrhagia for heavy plus irregular bleed. So what is classification of the etiology of the AB? That is Figo classification, Palm Cohen. Just remember, nothing to describe. For investigation history, to differentiate amount of bleed for differentiating this. General examination. Okay, nothing to explain here. Investigations. Okay, management, medical management. Okay. Okay. So now comes the medical management. So non-hormonal we get NSAID, mefenamic acid or naproxen to decrease pain, and they also decrease bleeding to some extent. Then tranexamic acid, this is decrease bleeding and it is an anti-fibrinolytic agent. Okay, now comes to hormonal to stop the bleeding. So progestins. So this is abnormal uterine bleeding. What progestin analogs will do? They will support the endometrium, then the shedding will stop. So progestin analogs are methoxyprogesterone acetate and Mirena. This is the most common. Methoxyprogesterone acetate most important. It will come in different formation. What we can also give is that either we can give alone progesterone analogs or we can give combined oral pills. That is that have both progesterone and estrogen, because both of them are, estrogen causes endometrial proliferation and this progesterone causes support to endometrium. So the endometrium shedding will stop and the bleeding will stop. So how will we use this progesterone analog and in this combined oral pills? So if the bleed is ovular, that is, how will we know that the bleed is ovular? That is, there will be pain associated, okay, with bleeding. So we can give low dose combined oral pills. Okay, in anoral bleed we will prefer progesterone analogs. Okay, this is not that much important, just know this. Then other are estrogen, we can give direct estrogen, danazol, mifeprostone. Okay, then this is, what is this? LNG-IS, levonorgestrel intrauterine system. Okay, just remember this. Surgical management. Okay, nothing to explain. Yes, management protocol of AUB, because the patient in OPD comes with this age group, and also the long question will also come with this age group. Okay, so if the patient is pubertal or adolescent, that is less than 20 years, then after ruling out pregnancy we will give medical treatment. If reproductive period cycles are regular, then we will go through medical management. Response, then follow up. No response, then we will, we cannot suggest investigation every patient with abnormal bleeding. So if the cycle was irregular, then we will think that this is not that major abnormality, so we will start medical management for 3 cycles. If there is proper response, then tell her for follow up. If there is not proper response, then we will have to do the investigation. If the cycles are irregular or frequent, then we have to assume that there is some pathology that is causing this, and we have to treat that pathology. So in irregular cycles we will directly suggest investigations. Okay, what are investigation? Same as before. Now if some pathology detected, treat accordingly. That is, some fibroid, some cancer, some infection detected, treat accordingly. If there is no pathology, okay, if family is completed, then we can suggest her LNG-IUS or ablation of endometrium or hysterectomy. If family is not completed, then we have to keep the endometrium intact, then medical management and LNG-IUS. So in the premenopausal or postmenopausal group, will directly suggest the investigation, because they are more susceptible to all the gynecological complications and the diseases, and all the carcinomas, fibroids, etc. So we will directly go to investigations. Same investigations before. When malignancy is excluded, then we will look at the endometrium by hysteroscopy. So if endometrium is proliferative and simple hyperplasia, then we will just give progestins. Okay, to support the endometrium that is proliferating already. If the endometrium is not proliferating or have atypical hyperplasia, that is, it is going towards malignant growth. Okay, so we will do hysterectomy to prevent any cancer formation. So if we give progestin to proliferative or simple hyperplasia endometrium, response, follow up, no response, same as before. Okay, so now come to fibroids. So Fibroids are composed of smooth muscle and fibrous connective tissue. So they're called myoma, that is from smooth muscle, fibromyoma from both, and leiomyoma also from both. And it is an estrogen dependent tumor. So increased age, early menarche, nulliparity, hyperestrogenic rate, PCOS. In all of these, there will be increased estrogen. Like in every cycle, female, experiences estrogen peaks. So if increase age, more cycle, more estrogen. Early menarche, late menopause, and late menopause, more estrogen peaks experience. Nulliparity is same, because in pregnancy cycles don't come, so progesterone peak don't come. But in nulliparity, more hyperestrogen. Okay, PCOS same, hyperestrogen rate. Obesity, peripheral conversion. Okay, so there is nothing to understand. Okay, this. So in subclassification of fibroid, that is, it can be submucosal. Okay, so this is red is mucosa, then this first blue is, this is our endometrium, then our myometrium, and the outer blue is our serosa. Okay, serosa, myometrium, endometrium, and this red is mucosa. Okay, so it can be submucous, it can be intramural, submucous, or subserous. So intramural is inside the wall of the uterus, that is in the myometrium. Submucous is, it is below the mucus. Okay, so this is 0, that is pedunculated intracavity. Then one is, it is submucous but is less than 50% intramural, that is inside the wall of the uterus. Then 2 is greater than 50% intramural, this is 2. Okay, this is submucous, below the mucus, but it is also intramural and greater than 50% mural. Then third is contracts the endometrium, but whole 100% is intramural. Then fourth is completely intramural and doesn't contact to the endometrium. Then 5 is subserosal, that is towards the serosa outer lining, but more than 50% is intramural. 6 is subserosal but less than 50% intramural. 7th is subserosal pedunculated, other is other varieties. So nothing to be explained, all symptoms. Okay, nothing to be explained over here also, just USG saline hysteroscopy, laparoscopy, biopsy, sonography. Okay, nothing is there to be explained, just you have to remember this. Okay, so now comes to surgical management. So we can do myomectomy because they are fibromyoma, that is arise from muscles. Okay, so myomectomy is done in patients who want pregnancy, that they have child, or they want more children and they're in the productive age and they want to preserve their endometrium so that they can have further pregnancy. So in them we cannot do the radical hysterectomy, we have to do myomectomy, just that removing only the myometrium. So in myometrium what we do is that we only enucleate the myoma, not whole of the myometrium, just the myometa, and leave the endometrium also intact. Okay, because they want further pregnancy in future. So when what is the contraindication of myomectomy, or when we should not prefer myomectomy, instead we should do hysterectomy in infected fibroid during pregnancy or LSCS. That is, if we accidentally found some myoma during pregnancy or during LSCS, you don't have to remove at that time. Okay, suspected malignancy growth, then there is we have to tell them that you should use some surrogation method or other method, that is due to malignancy we have to remove the whole of the uterus, otherwise it will spread. Or in post-menopausal women where they cannot have children, so why go under myomectomy? Because myomectomy is for sparing procedure for women who want further child, and menopausal women can't have a child, so there is no point of doing myomectomy in them, just straight away to the hysterectomy. Okay, there is nothing more to learn, it's just to RMY in the fibroids. Okay.